This video is going to go through and highlight the main differences between what Medicare Part A is, what Medicare Part B is, and what it's like for the patient and the therapist on each service, meaning via home health care agency, which is your Medicare Part A, or via outpatient therapy, which is what PTDU is on Medicare Part B. First is eligibility criteria. For Medicare Part A, home health care agencies, the patient has to be homebound. There's no other exceptions. The only reason Medicare Part A covers the patient's services is because every visit, someone is documenting that the patient is homebound. Stark difference between Medicare Part B. Medicare Part B, patients can or don't have to be homebound. So you can see either patients on those, your patients that are homebound or just someone out in the community. Like I said, that would typically go to a clinic, but you can now see them in the home under Medicare Part B. First is homebound versus non-homebound plays a big role in differences. Home health care agency, yes, they must have it. Part B, no, it can be anyone. Secondly, with the eligibility criteria, is for a patient to be on a Part A service, there usually has to be a change in function, meaning some type of decline that just happened, which is why most of the time you get patients directly out of the hospital, directly after a fall, directly after a sickness. Something usually has to have happened to cause the patient to be below their prior level of function. That is the role of a home health care agency. Or three, the patient needs nursing care. They got a wound and something happened. That would just go back to change in status. That is why most of the time you will see a patient via home health care agency is because they're homebound. They just had a fall or event happen, and maybe there's a wound that the nurse needs to take care of. All right, with Medicare Part B, the patient does not need to be homebound. There does not need to be a new, change in function, meaning they just had a fall or hospitalization. It could just be the patient wants to work on their nagging, lower back pain, or their generalized gait instability, or they're just feeling weak this month. Okay, we can get an order for all of those reasons. There's not the stringent requirements that there is for Medicare Part A when it comes to eligibility criteria. Right? 2, documentation and paperwork. All you home health care therapists know, I'm one myself. I was one myself. Oasis. When it comes to working with a home health care agency and documenting Medicare Part A visits, you are typically have to document the whole body, the whole systems. You're going through the meds, the respiratory, bowel and bladder. You're talking about, are they a high risk for rehospitalization? You have to cover all the ends of the spectrum, which is why your documentation takes you, 2 hours to do for those starter cares. And then on those Oasis discharges, you have to do the whole thing again. This is why Medicare Part B is 10 times better, meaning you're just doing a normal outpatient physical therapy visit. You only have to document what the patient, his goals are, what their needs are whenever it comes to their MMT. Do they need range of motion? Do they need to get stronger? Do they need to improve their TENETI? You are strictly doing a physical therapy note, as opposed to Medicare Part A, you are capturing the whole picture for the agency so they can then determine, is this patient at risk for a new hospitalization or event? All right, which makes it much, much easier. Medicare Part B, all your treatment notes, you're really just carrying forward the goals and you're writing a new subjective and assessment. All right, and also another different caricature between Part A and Part B. So Part B, we're billing units. So you're going to put at the bottom, you're picking the Therax code, their activity code, and that'll be for a different video or your documentation training about how to bill that. And you're just picking those and writing in the exercises, right? Part A, you have to cover the whole body. You always got to document homebound status. Are they a fall risk, X, Y, or Z? Part B, strictly physical therapy related. It is not the whole body system. They're much easier. They're much less time. That's the biggest thing, the less time to do. Therapist autonomy. For that patients with Medicare Part A, they are with a home health care agency, which means you have bosses, which means they're setting frequencies, which means you don't really get to decide what the patient gets. At the end of the day, it goes back to the owners of the home health care agency. They are the ones that get to pick the frequencies. They are the ones that get to dole out the visits. There's nursing, PT, and OT. They got to split it between the three. You do not have autonomy in the home health care agency setting to really run it how you want, to really get the patient as many visits as it is that they need, or to go out there when you want to see the patient. All right, Medicare Part B, via PTDU, you are picking your own frequencies. You can decide when that patient comes back on service. You get to, if you want to do twice a week, you want to do 3 times a week, great. You can decide between those things. You get to treat the patient however it is that you want to treat the patient. You can do community goals, which you can't do in a home health care agency. You have a lot more flexibility and freedom You want to see patients back-to-back days, or Monday and Saturday and the weekend. There are no 30-day reassessments, discharges that have to be by a certain day. Start of care has been 48. You have the freedom with Medicare Part B and PT to do to really run your own census and be mindful of how you want to treat your patients. For frequency of visits, and we touched on a little bit here, when you're writing a frequency for a home health care agency, they are the dictator at the end of the day with how many visits they give the patient. A lot of times they'll front load, meaning they'll do twice a week for 4 weeks, and then they'll throttle it down to once a week for 5 weeks after. And then you have to do your 30-day re-eval before X date, or a new order comes in and they want you to do the eval. You got to do it within 24 to 48 hours for the start of cares, or the research's got to be before the end of the episode. There are much more timetable and procedures with Medicare Part A that you have to follow that drive you crazy. Because let's say you're on vacation and you're not home for the 30-day re-eval. What do? With Medicare Part B, you get to pick your frequencies. You get to pick how many weeks you're going out to see them. You have all the autonomy it is. Just be mindful of their cap, which we said about 28 visits. And we go through how many visits they have left for the year. You want to be mindful of the time of year and those things. But you get to really decide the frequency when it comes to Medicare Part B and flexibility. Scope of care. Medicare Part A, your job is to get that patient back to its prior level of function. All right, let me say that again. It's prior level of function. They say, hey, John, I want to get back to doing running in the community. That is not your job as a home health care therapist. Your job is to get them back to being as independent as they can in the home and then discharge. They don't want you getting them back to doing hiking or back to pickleball or back to, being able to walk 5 miles. That is not your scope under the Part A. Part A is just getting them back to being independent in the home as best as they can, and 2, back to their prior level of function. If they were on a walker before their hospitalization and you got them back to being independent with the walker after the hospitalization, technically that's their prior level of function and you have to discharge. With Medicare Part B, you can make community goals. You can make home goals, but you're not restricted like you are in Medicare Part A to treat whatever it is and whatever goals that the patient has. You have much more freedom to talk with the patient on your eval and say, hey, here's how many visits that we got. What are you thinking? What do you want to get back to doing? What's giving you trouble? And then you can build that out for the patient. You're not going to be restricted to you can only have them walk a certain amount of feet or get them back to being independent in the home. Not the case with Medicare Part B. You have the scope to do whatever it is that you want to do in an outpatient clinic. So the scope is much more wide open when it comes to Medicare Part B and outpatient therapy as it is to home health Medicare Part A therapy.